My name's Jason. I work in the Scleroderma clinic here with Dr. Fisher, and this morning I want to talk a little bit about skin and Raynauds involvement with systemic sclerosis. So just a little bit about myself. So yeah, I've worked in the clinic, I think this is now my 8th year. Officially, I did fellowship training here, but worked with David Collier when he headed up the Scleroderma clinic here when I was a trainee, and then came on board as a faculty member. And I think systemic sclerosis is really an area that's in need of having some people who are kind of experts in that area, because it's not as common as rheumatoid arthritis. And so there's a lot of rheumatologists even who don't see a lot of patients with systemic sclerosis. And so, like Cindy mentioned, we're one of only a handful of programs across the country that has a dedicated clinic to this condition. And so I think it lends some level of expertise from that perspective as well. This is supposed to be kind of informal, so if you guys have questions as you go along, please let me know. I think, Cindy mentioned that sometimes if we get into doctor speak and I'm using a term that doesn't make sense, just kind of stop me and let me know that you want me to explain something, so I'm happy to kind of make this informal. I have slides just so we have something to kind of go off of, but I'm happy to kind of leave time at the end too for questions around this area. Again, we'll be focusing on skin and Raynauds involvement. You're going to hear a lot more talks today about gastrointestinal involvement, pulmonary involvement, and other manifestations. So we're going to go through. I was told I'm not supposed to move too much because I think we're on camera right now. So, all right. So we're going to start off with Raynauds Phenomenon. So Raynauds Phenomenon, it can actually be seen in up to 10 to 15% of the general population. We're going to focus here on what it looks like and how we approach it in systemic sclerosis. But not everybody who has Raynauds, thankfully, has systemic sclerosis. And so there's some clues to that. It tends to be much more severe in systemic sclerosis. And then I think if you see the bottom picture, if you can make out at the very ends of the fingertips, there's little sores, which some people will call infarcts. Some people will refer to that as digital pitting. When it gets to that stage, a lot of times an astute clinician will know that there's something else going on. Primary Raynauds is just a spasm of the blood vessels that lead to the end of the fingers. And so if you don't have an underlying condition associated with that, it really shouldn't cause enough lack of blood flow to actually cause sores. So when we see this, we're worried for something like systemic sclerosis. There can be other conditions that can cause sores in the end of fingertips, but more investigation kind of needs to happen at that point. And so, again, it's important for us. We're going to talk today. We're going to assume that we already know the person or individual has systemic sclerosis, but it's important for us to figure that out from the get-go, because the treatments differ if someone has primary Raynauds, which isn't associated with scleroderma, or if they have a secondary form. So what about non-pharmacologic management? And to be honest, even with systemic sclerosis, I'd say that probably half my patients are not on medications. They do things themselves to try to protect their hands and keep themselves warm, but not everybody is on medicine. And so some of the things that we can do that don't involve taking pills, I have listed up here. And some of them are very obvious, right? We want to keep our hands warm. We want to keep our core body temperature warm. Those are important things. Across the years, really, you guys have all taught me a lot of the tricks that you'll do. And so I've seen people have everything from the chemical hand warmers that I think we're all kind of familiar with, right? So you see them on the ski slopes, you kind of break them, and then they have a chemical reaction that releases heat. But I've actually seen people that have pretty clever solutions. So I have one patient whose husband is a hunter, and I guess Cabela makes this pair of kind of electric heated gloves that are quite nice. They're very expensive, but I've seen across the years a lot of people are very innovative in the ways they take care of their hands. But obviously it's important, and it could be something as simple as making sure that in your glove box of your car that you have some hand warmers available, because heaven forbid if your car broke down somewhere in the mountains in the winter, you want to have something there on an emergency basis. So that's something when I see a new patient with scleroderma, I try to sit down and take some time to explain the types of things that might be nice, just practical-wise. I have some other things listed here. Smoking cessation is probably the most important, and I think that's for many, many reasons. You're going to hear about interstitial lung disease and pulmonary hypertension later on, but you don't want two reasons to have a condition that could be worse, right? So if you have lung disease, you don't want to smoke on top of that and cause further injury. And this is the same thing with blood flow to the fingers. If you are a smoker, you have another reason to not have good blood flow to your fingers. So that's something that we always kind of talk about. And then there's, at the end, I have more invasive non-pharmacologic interventions. And so has anyone here ever had a digital finger injection for the Raynauds? No one. Okay. Yeah, so you can use, so this can be done in some situations, and I think at the end I can talk a little bit more about it if you guys want to hear, but I think in someone who is having what we would consider critical ischemia, so where we're concerned that really they might lose a part of their finger because of the lack of blood flow, it's something that's been described by Fred Wigley at Johns Hopkins, and I've done in clinic on probably 10, 15 people, and it can provide some relief, although it's certainly not perfect. And then more recently, probably in the last 4 years or so, Botox injections have been looked at as well. And again, towards the end, if you guys have questions about how that works or how effective it is, we can kind of talk about that. And then last would be a surgical procedure. So the blood vessels are innervated by nerves that can kind of control how clamped down or how narrow those blood vessels are. And those are called sympathetic nerves. And so the surgeons can actually do a procedure where they kind of strip off that innervation to the small arteries in the hands. And that can be used in some patients. And again, these aren't perfect options because they're not 100% in terms of success rate, and there can be complications. But these are something that we could talk about, especially in somebody that's failed kind of more traditional or early therapy. What about medicines? So again, at least half of folks that I see roughly are going to be on some form of medicine. And I think the one that we have the best data for are the calcium channel blockers. So we had very few people who've gotten injections. How many people are on something like amlodipine or nifedipine for the Raynauds? Okay, yeah. So probably only about 20%, 25% it looked like. That's the only drug that has strong randomized controlled data. And so I think that's not to say that everything else on the list can't be used and that we have not used them. But in terms of actually having a lot of data in the literature, calcium channel blockers help, and they relax the arteries that supply the end of the finger. So it would make sense that they may have some role in improving blood flow. And so usually that's the medicine that we'll kind of start first. So if I have somebody who needs medication, either because of pain or they're developing sores, that's the one that we'll start with first. It's cheap, it's well tolerated, and I think it has some good evidence. And then if that doesn't do everything we want it to do, or if there's side effects, then we can kind of go down the list. And I have them divided here into medicines on the left that will kind of help blood flow or dilate the blood vessels, and then medicines on the right that you could consider that make platelets less sticky, and so that you might, there's some theoretical reason to use them that it might improve blood flow as well. So how do I approach this? I usually approach that if someone doesn't have a stomach condition or another reason that they might have a bleeding problem, a lot of patients I'll put on a baby aspirin or a low-dose aspirin, and then we'll talk about calcium channel blocker therapy. And again, if that fails, then we can kind of go down the list in terms of other blood pressure or vasodilating medications. When you get down to what I have listed here as others, those are medications that are used for pulmonary hypertension. They're not FDA approved for Raynauds, so that translates into it can be really hard to get them approved by insurance companies, but it's something that we'll consider. So sildenafil is a phosphodiesterase inhibitor that's commonly known as Viagra or Revatio. And so that's a medication that has some role in helping with Raynauds symptoms as well. And it's something that we'll try in select individuals who might get some effect from these earlier or these agents above, but not enough. Do you guys have questions about that? Yeah. Yeah. No, so sometimes some medications can have epinephrine in them. So sometimes lidocaine or other kind of anesthetics can have epinephrine. And then if you were injecting something like in your hands or in your fingers, the epinephrine part of that can clamp down on the blood vessels and make things worse. But a lot of times they can make anesthetics that don't have that component with it. And they would just, and most folks, if you have Raynauds, most docs would know that, but yeah, you would want to tell them that, yeah, there shouldn't be epinephrine in any kind of injection you're doing in your hands or a person with scleroderma. But the actual anesthetic itself should be fine, assuming that you don't have an allergy. I'm not aware of folks with scleroderma having higher rates of allergies to anesthetics. Arya?
Yeah, can you expand on the PAH, issue here? So these drugs are maybe effective, but we just can't get them. Is that?
Yeah, so the medications that so Dr. Fisher is bringing up the question of what does it mean that they're not really approved for this indication. So they're all FDA approved. All forms of those three medications or three class of medications are approved and shown efficacy and survival benefit in pulmonary hypertension, and they work in that setting because again they dilate the pulmonary artery, which relieves some of the pressure in that vessel. And so there's a theoretical reason that they should be effective, and they actually have shown benefit, but the data has not been strong enough that the FDA thinks it warrants a new indication for that. So I think what we'll normally do is, I think of the three things in that list, sildenafil is the one that I probably prescribe the most just because it doesn't require as much monitoring for liver abnormalities, and it's a non-invasive medication. It's an oral pill. I'd probably say that, somewhere around 30% of the time, 40% of the time, the insurance company will agree with me that it's reasonable in a person who's failed other lines of therapy. But there's other times where it's not. And then it's a decision about whether it can be afforded out of pocket without the insurance company help, which is difficult. That's a great question. You can probably order anything you want from Canada or those other countries. I'm not going to be covering GI today, but Paradone is a medication that I have some patients who go to Canada or through Canadian pharmacies to get that medication. So I would probably imagine you could. I mean, again, what I tell folks is that it's not unreasonable to consider those options, but I do, we do need to be careful. There might not, depending on if you're ordering it from Canada, doesn't mean you're actually getting the drug from Canada. It could be from overseas. And then you just have to wonder about how stringent the regulations are in that country so that you know what you're getting. So that's kind of like my one editorializing on it. Yes? Mm-hmm. Well, they can be problematic and maybe worrisome to use the objects or the line of therapy on the right. So if someone has very low platelets, I might be reluctant to give them an antiplatelet agent just for fear of bleeding. In terms of vasodilating agents, I don't see a reason why you couldn't use those. There is some concern when you start getting down to way down in the list, the last one, prostacyclin. That's an IV medication for the most part. That might have some antiplatelet effects too, but I've had patients who've had really low platelets that we've had to admit to the hospital to give that line of therapy, and it was fine. So, yeah. All right, well, we'll keep going through. And again, if you guys have questions at the end too, I think I've allotted this not to last 45 minutes so that we can go through questions. So on the skin disease, this is obviously a hallmark of systemic sclerosis. There is a subset of individuals who might just have pulmonary and gastrointestinal involvement and not have the skin involvement. But for the most part, most of the patients we see have some level of skin involvement, even if that's not their primary concern. And in some folks, it certainly is the biggest problem that they have, and that it's life-altering. So involvement early on, this is a picture of a person's elbow who has kind of like an early inflammatory phase. And so involvement normally starts at the fingers and the hands, and then it can ascend or move proximally, so up towards the chest. The face is another common area of involvement. And I think, has everyone heard the terms limited and diffuse in terms of like their categories or subset? So we think those are helpful. We define limited as being anything beyond the elbows, beyond the knees, so distal to that area, and the face, but no upper arm, upper leg, or chest involvement. So that's the limited subset. And then diffuse would be anything that has those areas of involvement. We think that can be helpful because you tend to have different risk in those different groups. So folks with limited might have a higher risk of pulmonary hypertension, whereas the diffuse individuals with diffuse disease have a risk for kind of rapid progression of their skin and their lungs early on. So it just kind of helps us and the patients know what we need to be concerned about, although, to be honest, we're watching for everything, but it still kind of helps us to give some prognostic information. So in terms of skin involvement, what's difficult about it is that we don't know when someone walks in the door, we don't know how bad their skin is going to be 2 or 3 years later. And certainly some people have fairly mild disease that kind of stays at a mild level. And so we don't want to put everybody on medications because, as you'll see when I go through slides, the medications can have a lot of side effects in and of themselves. So I think an area of research, in addition to trying to find medicines that work, is going to be to try to find the optimal timing of when we intervene and whether we should be intervening on people earlier in the course based upon blood work that might predict them to progress. So involvement of the chest can pose a problem, not only just because of the level of discomfort, but then also you can kind of imagine if your skin is tighter on your chest, that can kind of decrease the amount you're able to open up your lungs and get air in. So it's important just to realize that there's more than just interstitial lung disease that can make it hard for a person to breathe. And then probably the biggest functional problem that we see in terms of skin involvement is that usually the skin, that when it gets involved around a joint, that coupled with tendon involvement can lead to flexion contractures. And I think that's, at least in my experience, in addition to the pain of having skin involvement, that's probably the biggest problem that I hear from folks with scleroderma, is that because of that functional impairment of not being able to kind of open and close your hand as much as you'd like, then that's something that can be really, really tough for somebody in their day-to-day life. And so it's certainly something that I take into consideration. So even if somebody has limited disease, in my estimation, if they are starting to have any kind of concerns for loss of range of motion in the hands and wrists, because we use those every single day of our lives, I'll consider using medications early on in that setting as well, again, even if they're not in the diffuse subset. And then this last one, not everybody who has scleroderma has what we call salt and pepper skin. So this is an African-American individual who actually has, what might get misdiagnosed as vitiligo. And so what you can see is that there's a bunch of kind of dark spots that is actually the normal skin pigment, and then there's hypopigmentation or whitening around the hair follicle. Why that happens around the hair follicle, we're not exactly sure, but I included it because a lot of people have said there's certain things that we can see that really make us think strongly of scleroderma. And if someone has Raynauds and has salt and pepper skin changes, there's very, very few other things that are going to cause that. So it's something that I look for. And there's other characteristic features that we sometimes can see in terms of a lot of folks with scleroderma. If they've had facial involvement, they can get furrowing around their mouths. And that's something that's not usually seen with hardly any other condition as well. So again, we try to point that out to our trainees because, we are a center of excellence, but we can't see everybody in the, entire mountain region. And so we're really dependent on people picking up these changes first so that they can get appropriately referred in to see us. So what about medications? And again, after this, you guys are free to ask me about any of these. So these are ones that I think I probably regularly use in terms of how to treat skin involvement. So prednisone, it's kind of a controversial area because you can get too much of a good thing. And so there's a risk with high-dose prednisone in terms of potentially making you more likely or worsening your outcome with something called scleroderma renal crisis. That's usually been shown with higher dosing regimens. And so I usually try to keep dosing under 15 milligrams, usually around 10 milligrams. That's usually helpful kind of early on in the process when the skin is more painful. Sometimes we can pick up clinical signs that there's more kind of skin edema going on. And I think in that situation, prednisone is the only medicine we have that works quickly. So how many folks are on methotrexate or mycophenolate right now? All right, good. Well, I think you guys probably have already gotten the spiel from whoever put you on that medication that it can take 2 to 3 to 4 months for that medicine to be effective. So if someone's early on and in a lot of discomfort because of their skin and they look like they have an inflammatory phase, Prednisone is the only thing that may potentially help their symptoms right away. All the other medications, it's going to take a while for it to be effective. Methotrexate and mycophenolate are probably the most commonly used because they're oral pills and they're much less toxic and invasive than the ones I have below on that list. The data, there's some randomized trial data for methotrexate, and then there's mostly observational studies for mycophenolate, although in the last year there was a big lung study that was a randomized trial that looked at mycophenolate's effectiveness for interstitial lung disease, and then it looked at skin scores as well, and it showed some benefit mostly in the diffuse subset as well. And then the last ones that I have on the list include cyclophosphamide, which is Cytoxan. And, this is more commonly used in interstitial lung disease. I've used it in some folks with just skin involvement, but it is a much more toxic medication. There is a cancer risk associated with kind of prolonged or accumulated doses of cyclophosphamide. It's low, and in some patients, it's a much better, I'd much rather take the risk of that than of their interstitial lung disease taking off. But in someone who has skin-confined disease, that's a discussion that has to happen if it's my patient between me and them to know if the risk is justified in that setting. And then IVIG, there's some single-center data at Johns Hopkins that I've looked at that. IVIG is a monthly infusion. Usually you get about 3 to 4 days of an infusion. And it's kind of like if you're not a blood transfusion, but you're getting pooled antibodies from the community. And so people who don't make their own antibodies need to get this form of treatment so they can protect themselves against infection. But there's a role in some autoimmune diseases. And this one's been looked at again by the Johns Hopkins group. And I think the data is not bad, but it is very invasive. You can imagine if you're signing up for 4 consecutive days of an infusion for the rest of your life, that's pretty invasive as well. So I only have a handful of folks that I've actually tried that with. Do you guys have questions about some of the medicines or that I have listed up here? Yeah. Yeah. Mm-hmm. Yeah, no, that's a great point. So occupational therapy and physical therapy are very, very important, especially early on in the process, because what's hard is if someone has had the condition for 10 years and has a very kind of limited range of motion in terms of those flexion contractures, that can be very, very difficult to work with. So I think, is Cindy still in the room right now? So is it Janet Poole? Is that the name of the occupation? So I know the Scleroderma Foundation online has some handouts. She's from New Mexico? Yeah. So I think she has some handouts on occupational therapy and exercises.
I just didn't know if it helped at all. So it sounds like it's early in the disease. It would be helpful to try to do as much as tolerance.
Yeah. And that's you bring up an important part about tolerating. The one area of concern or thing that I would caution people on is that trying to go to someone who's actually heard of scleroderma is important, in terms of occupational therapy, because I've had some folks kind of forced into a splint. And it's not that there is some data for splinting, to try to keep you from developing flexion contractures. But you can notice, I'm sure a lot of folks, if you even take your own hands and you have scleroderma and you try to straighten them out, you can see that your Raynauds or the pallor, the whiteness of the fingers gets worse. And I've had some patients develop worsening sores in the ends of their fingertips. So I think sleeping with them on, not a good idea because you don't want to wake up to a black finger. But yeah, I think working with somebody who understands that and then just kind of making sure that if it's really uncomfortable what you're doing, you have to kind of rethink things. Paraffin wax. It certainly, if you don't have any active sores or anything else like that, because you don't want to, the only concern I would have is, getting an infection in an area that was open. It certainly wouldn't hurt. It just basically, did everyone hear that question about paraffin wax? Cindy, I've not been doing a good job of repeating questions, sorry. So the question was about whether there's a role for paraffin wax, kind of baths, similar to what they use in rheumatoid arthritis. I think, certainly it's warm, it's going to feel good. And then a lot of times in rheumatoid arthritis, at least, when it cools, then it kind of provides almost like a compression, which kind of makes the joint feel a little bit better too. I wouldn't have any problems with somebody trying it. Yeah. Okay. I think I just have a couple more here, and then we'll have some time at the end. All right, that was a good segue. Occupational therapy was the next thing on the list, physical therapy. So other stuff, skin itching can be, a really, really bad problem, especially early on. It's usually worse in the first year to 2 years. So pretty much everyone, I would recommend that they go on some form of moisturizer, because the problem is that the skin involvement can really obliterate kind of sweat glands and other things that normally kind of lubricate your skin, and that can make things a lot more itchy. So I think that's usually a good idea. Sun avoidance and sunscreen I have. And then in terms of what to do for itching, it's problematic. It's really tough to actually treat somebody who's having intense itching from scleroderma skin involvement. But I've listed some of the things that I've tried. So I think moisturizers or oatmeal baths are something that people can do on their own, and I think can provide some relief. And then there's medications. The problem with a lot of the medications, though, is that most of the things on that list, other than low-dose prednisone, can be sedating. And so, meaning that some folks, they don't really like the side effect of feeling like they're sleepy during the day. But some of these things like antihistamines, or then I have 2 medications at the end that are used for nerve pain, but they've been shown to be effective when I've talked to folks around the country about what they did for their folks with scleroderma. Gabapentin is also known as Neurontin, and pregabalin is known as Lyrica. And those medications, I've talked to Virginia Steen at Georgetown and some other experts, and that's kind of what they've described using as well. How about anyone here? Any ideas for, in terms of, is itching been a problem for anyone in the audience? Any tricks that you guys have figured out that I haven't listed here that have been helpful? Okay. Sometimes, I've been to a lot of different support group meetings too, and I'm always amazed. Every time I go, I get a lot out of those meetings too, and usually there's someone who says something I've never heard of before, and I'm like, that sounds like a good idea. All right, and then the last slide I have here are just medications that I think need a little bit more study, and I think there's reason to be hopeful in the treatment of skin fibrosis, because I think there's studies that are currently underway, and there's studies that are probably going to be underway in the next couple of years that might offer us some better options. Not sure why I had that order there, but so IVIG, again, there's single center data at Hopkins, but now they're actually doing a randomized trial at Johns Hopkins and at Georgetown, so that'll be helpful because, again, it's an invasive procedure, so I want to make sure it's actually effective. Rituximab has been looked at mostly in observational studies, but again, randomized trials are ongoing. Imatinib or Gleevec is a medication that had a lot of promise initially, because the medications that I've listed so far, those are all medicines that kind of dampen your immune system or the immune response, but none of them are specifically fibrosis inhibitors. Imatinib showed some benefits in kind of mouse models of fibrosis, so everybody was really kind of encouraged by it, but the results in human studies have been really disappointing. But there's a sister drug, nintedanib, that I'm going to show in a second here, that it's now FDA approved for idiopathic pulmonary fibrosis, and they're going to be studying it in scleroderma as well. So we'll have some data in the future here about direct antifibrotic medications. So the 2 medications, nintedanib is the one I just mentioned, pirfenidone is another medication, and again, these have been studied for pulmonary fibrosis. They're going to be looked at. I think nintedanib is now enrolling, right? REA is saying yes to that. We're enrolling for a trial of interstitial lung disease and scleroderma, and I'm assuming there's secondary endpoints for skin as well. Yeah. So we'll have some, because it's a lung study, that's what the primary purpose of the study, but we'll also get information on skin involvement. And then pirfenidone will be enrolling in the future as well for a similar study. Transplant. So we've kind of talked at prior scleroderma patient education days about the transplant option. It's an aggressive form of therapy. So essentially, it's a bone marrow transplant where somebody gets a lot of medication to wipe out their own immune system, and then they get their own stem cells back. I think it's an area that still needs more research. I think it holds a lot of hope because there's some evidence that it might actually, instead of just stabilizing some of the symptoms of scleroderma, might actually cause some improvement in lung function test. But we usually reserve that for a subset of folks because there can be a risk of death just from the procedure itself. And so, again, it's not something that everybody should get, but it's a role, or there's a role for it for some folks. And then 2 medications that are currently used for rheumatoid arthritis. One's called abatacept, and another one's called tocilizumab. Kind of have ongoing multi-center trials right now. And so, those medications, kind of similar to the other ones, those are used for other rheumatic diseases, but the thought is that we'd like to know if there's any kind of signal for benefit in systemic sclerosis as well. We do not have anyone, or we don't have those studies open right here, right now. So I'm not sure. I'd have to look. I'm not sure what the closest center that might be doing those. Yeah.
Yeah, we considered in participating in both. Those 2 trials are placebo-controlled.
Yeah,
so
that's a good point.
What Jason and I talked about was not feeling comfortable putting patients in a trial with progressive skin, not giving them therapy when we knew we had things like mycophenolate, methotrexate, IVIG, rituximab, Cytoxan to choose from.
Sure.
The trial that we do have open is the nintedanib trial, which is an interstitial lung disease trial. I'll talk about that. It has secondary outcome measures for skin.
And that's add-on.
And I just wanted to explain why we're not participating in those 2 trials.
And that one's add-on, correct? Nintedanib?
Nintedanib is add-on, so even though it's placebo-controlled, background mycophenolate, background cell cycles are out.
Yeah, thanks. That's a good point. I think that's it. We left a little bit less than 10 minutes, so we have some questions. Yeah, so the paraffin wax. So yeah, we had, so it can be helpful, I think, in terms of the warmth, but it's not something I've prescribed or advised for a lot of non-rheumatoid patients. But I think as long as you don't have open sores, and if you find that it provides a benefit, that would be reasonable. Yeah.
2 questions. One, does Raynauds affect feet? Because I know my toes can hurt.
Sure.
And you didn't mention much about feet.
Yeah.
Is that related to scleroderma?
Yeah, so the hands and feet can be involved. I think the hands, if someone had feet and no hand involvement, that would be a little bit of an odd way to present. But people can certainly get bad blood flow problems in their toes as well. It's usually areas that are further away from your heart, so the small blood vessels that are affected. So the feet and the hands are common areas. It can happen in primary Raynauds too, though. So I think the second part of your question was, does it mean... I wouldn't know if someone had hand and foot symptoms that they definitely have scleroderma. We'd have to ask a bunch of other questions and examine them to know. But it can be a problem. All the medications that we talked about for hand Raynauds could be used for Raynauds of the feet, the toes as well.
Calcinosis, is that like quite a different topic?
Yeah, well, it's a different. So the question was calcinosis, and is that a different topic? So calcinosis, we don't actually know why people with systemic sclerosis can get calcium deposits. The thought is maybe it's a blood flow injury response, so you don't get enough blood flow, and that's thought of because a lot of times they tend to form at the kind of fingers, toes type area, but they can form in other regions as well. That's a tough area because there's not a lot of strong medications in terms of options for that. Probably maybe in between one of the talks, I'm happy to talk to you a little bit more because there's probably less evidence than anything I've talked about for this. So I don't want to espouse that this is the way to do calcinosis treatment. Yeah.
Rubber band, and my skin elasticity has changed greatly, and maybe it's my age. I don't know, but it's like my legs look like they rubber band, and if I lose weight or whatever, and it's just, have you ever heard that? It's just like skin.
So is it less?
Elasticity in the skin is, I don't know if it's an issue.
Well, it depends on what you mean by. I mean, I've seen a lot of folks with a lot of times with scleroderma. Not only do you get the skin tightening on top, but a lot of times like the fat layer underneath our skin that kind of gives it a bounce and kind of a softness. That a lot of times you can get inflammation there that kind of, and the fat layer can kind of, for lack of a better word, dissolve. And so a lot of times just like the skin texture is different and the kind of bounciness of skin. Not sure if that's what you're describing though, when you describe it as like a rubber band.
It just looks very, we can talk later.
Okay, all right. Yeah, over here, sir. Yeah, I think scleromyxedema, does that sound like that's what you're talking about? So the question was like stomach and chest involvement in scleromyxedema is what I would consider a systemic sclerosis, a mimicker. So it's another fibrotic skin condition, but it's not systemic sclerosis. And so sometimes if someone only had chest involvement, that wouldn't be typical, right? Because we were saying before, it usually starts at the fingers and then moves up. So if someone has like abdominal involvement, then morphia, which is like another skin fibrosis condition that's not systemic sclerosis. Sometimes chest involvement would kind of pique my interest about, are we sure this is systemic sclerosis? The way to differentiate with scleromyxedema usually is a skin biopsy. So if someone presents to me classically for scleroderma, finger involvement, Raynauds, digital pitting, maybe antibody testing, I'll rarely send them to a dermatologist for a biopsy because it's a clinical diagnosis and I'll feel very comfortable. If someone only had chest involvement or chest predominant involvement and didn't have those other features, then I think a lot of times we'd probably pursue a biopsy to make sure we don't have something else. Because scleromyxedema can be from kind of blood cell problems that would require a totally different treatment. Yeah. To me, if you got chest involvement later, I don't know that would raise my concern for scleromyxedema. But again, there can be a lot of other nuances in your particular case that I don't know. But I think when it's brought up, usually it's because we want to make sure we have the correct diagnosis. Like when we look for that, I think, yeah.
Yeah, I have a lot of foot pain, like pins and needles. Can't walk some days. Is that related to scleroderma?
So the question was pins and needles type pain in the feet to the point where sometimes it's really difficult to walk. Neuropathies, that sounds like a nerve type pain, and neuropathies have been described in scleroderma. Sometimes they can be because the nerves themselves get pushed on, like at the wrist. If there's enough tightening around the skin, it can push on the nerves that kind of travel through that area. But even in cases where someone doesn't have like clear tightness around the ankle, neuropathy still can be a problem. And so the treatment of that, it can be problematic. If it's mostly pins and needles, then some of those nerve medications that we talked about before, gabapentin or pregabalin, sometimes can be helpful. It's more difficult when someone can't really feel their foot and then they have balance issues because those medications that I mentioned kind of decrease pins and needles type symptoms, but they don't like give you feeling back. So the balance issues can be a little bit more problematic. Yeah. Maybe I think we have time for like 2 or 3 more. Yeah. No. So the question was, if someone presents with primary Raynauds, can it precede or predate like development of secondary Raynauds? So the answer is yes. Yes. I mean, most folks with systemic sclerosis have symptoms of Raynauds for like 8 to 10 years before they develop a non-Raynauds symptom, and so it can predate it. I mean, what I would say though is that in that person, they just deserve to be kind of monitored closely because so many people can have primary Raynauds. We wouldn't want to work every single person up. But I think if that Raynauds worsened over time, and if you notice, kind of heartburn symptoms, breathing problems, anything, I think we'd want to watch that person closely because yes, autoimmune diseases in general kind of develop over time, and that's why a lot of folks are kind of not diagnosed for years because it doesn't start off as usually 10 symptoms at once. It's usually one symptom, then another one before it fits a pattern. So yeah, that's a great question.
I did an online, I was a participant in an online research study where they educated you about stuff. And one of the things they said is when you're having
It's affecting what?
Capillaries in your lungs or oxygen is, I wondered if that's true.
Yeah, my understanding, and I might ask Aryeh to see what he kind of thinks too, is that the data for internal vasospasm, that there's not a lot of great data for that. There's a lot of, it is theorized. So like we know that folks with can get heart involvement, like cardiac involvement with systemic sclerosis, and I've seen people kind of postulate or hypothesize that it might be from a vasospastic component. But I don't think we have strong data for that. Certainly the patients that I have with really bad Raynauds, I haven't seen a necessary connection between like internal organ involvement. I don't know, Aryeh, if you feel any.
I think it's a nice, Dr. Bull is going to talk about pulmonary hypertension, and that's probably our closest
Sure.
corollary, that scleroderma is
Yeah.
a vascular disease, and just like you can get peripheral vascular involvement, you can get pulmonary vascular involvement and renal kidney vascular involvement. We don't think of it as sort of the acute vasospasm leading to pulmonary hypertension. It's more of a chronic vascular process.
Yep. I was given the 2-minute warning, so I think that's it. I'm happy.
Just wonder,
Yeah.
maybe the stem cell, like who do you consider, or who would we consider for stem cell transplant? Because that comes up a fair bit.
Yeah. I mean, I think it'd be someone who a lot of studies too require that you've failed something initially, but I think in my mind, if there's a family member of mine, I would try methotrexate or Cellcept or both before I would move on to stem cell therapy. It'd be my feeling. I think that there's promise for it, definitely, because those agents, methotrexate and Cellcept, it's not like the data's rip-roaring in terms of response to those medicines either. But I think that the toxicity, so again, my understanding from the European trials was that there's something like a 2 or, no, is it higher than that? Maybe there's like a 5% 30-day mortality. It's 1 in 20 patients that you're going to treat that could die within a month. And so that was really thought to be treatment related. So I think there's a risk of it. I think it might hold benefit, but I would not certainly want to put someone on that as first line therapy.